Welcome to the first in Turning Point's new webinar series, Issues in Breast Cancer Survivorship. I'm Jill Binkley, Program Director and founder of Turning Point. Turning Point is a nonprofit based in Atlanta, Georgia, with the mission to improve the quality of life for women and men going through breast cancer by providing and advocating for evidence-based breast cancer rehabilitation, while eliminating geographical, racial, cultural, and socioeconomic barriers to care. This webinar will be recorded and it can be accessed after the webinar at myturningpoint.org. We really welcome your questions. Please put them in the Q&A and we'll address as many as possible at the end of the webinar. We're excited about today's important forum on racial disparity in breast cancer survivorship. We have an incredibly talented panel who will delve into the issues and discuss strategies for change. And now it was my pleasure to welcome our moderator. Dr. Robert Smith is a cancer epidemiologist and Senior Vice President for Cancer Screening at the National Office of the American Cancer Society right here in Atlanta. He's an adjunct professor of epidemiology at the Rollins School of Public Health at Emory University. His primary research interests are cancer epidemiology, evaluation of cancer prevention and early detection programs, as well as quality assurance in the delivery of health services. At the American Cancer Society, Dr. Smith leads the development of cancer screening guidelines that have saved uncountable lives worldwide, including mine. He's the author of over 350 peer-reviewed scientific articles and book chapters, including a recently published book chapter on disparities in cancer screening in the United States. It's truly an honor and pleasure to welcome Bob as today's moderator. Turning it over to you, Bob.
Thank you, Jill. It's very much of a pleasure to be here with you today and to help moderate this session. Matt, may I have the first slides, please? We're going to talk a little bit about disparities in breast cancer survivorship, to set the stage, and then I will introduce the panelists and we will begin our discussions and questions and answers. Next slide. There is clearly, and it's a well-established need for breast cancer rehabilitation and exercise. Breast cancer survivors experience multiple neuromuscular, musculoskeletal pain and functional disorders as a result of cancer and its treatment. And they commonly report that they were not prepared for this experience and that they commonly do not get support while they are experiencing these sequelae long after treatment. Next slide. And categorically, we can describe these imparities. There are limitations in upper extremity function in breast cancer survivors. These are well documented and they're linked to a reduction in the ability to complete activities of daily living. These include pain, reduced mobility, weakness in the upper extremity and trunk, and I think worst of all, lymphedema. There is reduced quality of life, diminished quality of life, and impact on work and family roles that have been reported extensively. These include psychosocial and emotional trauma, the family role and work disruptions, and sexuality and body image issues. Next slide. And there's a substantial reduction in quality of life with patients with metastatic disease and other vulnerabilities such as financial toxicity. There is fatigue related to surgery, chemotherapy, and radiation. Chemotherapy related peripheral neuropathy is well documented. There are secondary issues associated with balance and cardiorespiratory morbidity and osteoporosis. Next slide. Now, when we look at these common impairments that women experience, it's especially discouraging because we have especially strong evidence supporting the safety and efficacy of cancer rehabilitation as part of the treatment experience. Exercise in particular, and the prevention and management of many of these breast cancer-related impairments, including shoulder dysfunction, lymphedema, fatigue, osteoporosis, as well as function. and that these impairments can be minimized if there is early detection of women who are experiencing them. Exercise has also been shown to reduce breast cancer recurrence. Next slide. And despite the fact that we have this very strong evidence about the effectiveness of rehabilitation and exercise, it's estimated that fewer than 20% of breast cancer patients are referred to rehabilitation during and after their treatment. Some of the reasons for this are well understood. There's a lack of availability of oncology rehabilitation care that is both magnified in men and women with advanced cancer and minorities, lower SES groups, and women outside of tertiary care centers. The separation of rehabilitation and oncology years ago outside of the same setting has been a barrier. There are lack of appropriate community-based clinical environments, limited multidisciplinary relationships between rehabilitation and oncology surgical professionals, and there are unclear guidelines for referral. There also is clear financial toxicity related to a cancer diagnosis that also is a barrier. Next slide. Now, racial disparities frustratingly exist in all aspects of breast cancer. They have discouragingly been with us for years. They are enduring, and unfortunately, we do not seem to be making the kind of progress against them that we should have. However, this forum will focus on the impact of disparities on breast cancer survivorship. And I want to just run through a few enduring relationships that we've seen. Black women encounter more physical impairment related to breast cancer than their white counterparts, even when access to care is equal. Black and low-income women are almost twice as likely as white women to have signs and symptoms of breast cancer-related lymphedema. There is a negative impact on the ability to work following breast cancer treatment that is greater for Black survivors of breast cancer compared with whites. And the prospective model of breast cancer rehabilitation at Grady Hospital in Atlanta has shown that predominantly Black patients, in predominantly Black patients, over 30% of the patients experience significant issues following surgery, including reduced mobility, function, quality of life, and lymphedema. And it's very likely that these patients would not ordinarily have been referred to rehabilitation. And Dr. Gabram is going to talk with you more about that. I also should note here, during this period of time of COVID-19, we need to remind ourselves that it's not just this particular virus that has exacerbated racial disparities, but literally pandemics that we will experience in the future and other health disruptions as a result of natural disasters also exacerbate racial disparities. And there's a growing literature that's begun to document these outcomes. Next slide. Next slide, please.
I think that's the end. I think that's the end of that. If you want to go ahead and introduce that panel, Bob.
All right. So let me go ahead and introduce our panel then. Are we pulling up our videos now, or shall I just go through this? Let me do this. So Dr. Karen Wingfield, well, before I say that, let me just say that each of our, in the interest of time, each of our panelists have an exceptional background of experience and credentials. All of them have worked in the area of breast cancer disparities. All are national experts in their field. Dr. Karen Wingfield is a radiation oncologist, a national expert in community engagement, and the incoming executive director of the Meharry Vanderbilt Alliance. Dr. Lisa Van Hoos is a board-certified clinical specialist in oncology physical therapy at the University of Louisiana Monroe, and Dr. Cheryl Gabram is a breast surgical oncologist and professor of surgery at Emory University School of Medicine, and provides care to breast cancer patients in the Grady Health System. And Dr. Janae Finley is a physical therapist with a background in orthopedic physical therapy who specializes in breast cancer rehabilitation at Turning Point. Dr. Gabram and Dr. Janae are also breast cancer survivors and will share their experience with you today and the experience that they bring to caring for their patients in their settings. So welcome to all of you. We're going to begin our discussion today, our conversation, by asking each of our panelists to tell us why they are passionate about addressing the impact of disparities in breast cancer survivorship. And Cheryl, I'll begin with you.
Thank you, Bob, for your introduction. It is really quite an honor to join my fellow panelists discussing such an important topic. I'm extremely passionate about disparities in breast cancer rehabilitation for 3 reasons. I've been a breast surgical oncologist for 24 years, and during the recent 15 years, I've practiced in a safety net hospital. I've personally witnessed how survivorship care and breast cancer rehabilitation can take a back seat to other priorities that patients are dealing with as they complete their year-plus-long journey of cancer treatments. We were lucky to have lay patient navigators in our Avon Breast Center at Grady, who were breast cancer survivors. And we even engaged them in one of our survivorship studies to reach out to patients and further emphasize the importance of this last segment of care, encouraging them to proactively address all functional deficits and other after treatment effects so they, the patients, could realize an improved quality of life, in the end, putting the patient back in the driver's seat. The second reason I'm passionate about this subject is to get the word out that breast cancer rehabilitation has a positive effect on survivorship, in part because of the physiological benefits of exercise and its effect on improving perioperative outcomes, treatment side effects, quality of life, decreasing cancer recurrence, and improving overall survival. As a surgeon, I offer my patients the best care, so it's important for me to explain that exercise and rehabilitation is an essential part of that treatment. Lastly, I'm passionate because I'm a breast cancer survivor who was treated in a timely fashion at Turning Point. I never appreciated the importance of physical therapy until I had extensive bilateral breast cancer surgery myself that included an axillary lymph node dissection on my dominant arm. My own experience with axillary web syndrome and limited range of motion that was completely treated with breast cancer rehabilitation and allowed me to return to work as a surgeon now for nearly 10 years is a personal driver to make sure that all breast cancer survivors, men and women, have access to this last phase of breast cancer care.
Thank you, Cheryl. Lisa, would you like to go next?
Yes, thank you so much. And I agree with Cheryl. I'm very excited about today's conversation. And first of all, I'm interested in the topic because it is my community. So I identify as Black specifically. I identify as African American, so that is my subgroup within that definition of Black. And then I will be the first to admit, as a physical therapist, I was drawn to the field of oncology because I've always had this desire to help in regards to, and not just helping just to be out there, you know, like that's the general healthcare professionals comment, but I really wanted to address inequities in my life. I feel like that was why I was called into existence. And so I was able to do that as a PT. But then once I went back and did some additional training and started my research career, I actually got pushback, y'all, in regards to people saying, well, if you're going to be in this area of rehabilitation and oncology care, you should probably focus on the dominant group, right? Which is the Caucasian, European, American female group, because that's going to be an easier group to work with. And I was torn early on in my career about that, right? Because as someone from an underrepresented minority, part of your calling, part of the hero's journey is to come back to the community and to help lift up that community. And so, to be honest, it took me years to get to this place in my research where I am unapologetic about the fact that my research is predominantly focused on Black communities. And so that was the self-reflection and the work that helped me to get to this place today. And so I'm really excited about today's conversation. And I even wore my PT superhero shirt because I think PTs are awesome. And it is PT month also. So super excited to be with y'all today.
Awesome. Well, thank you so much, Turning Point, for having this great panel and for opening up a discussion around the importance of survivorship care. And, I'm a radiation oncologist. I do treat patients with breast cancer, and it's vitally important to have discussions around what it means to be a survivor. And frankly, I think the definitions are all over the place for some folks, but I believe that survivorship begins at the time of diagnosis. And we've got to start caring for people and making sure that they have all of the tools that they need, not only to survive cancer, but to survive it well. And from my experience, Black people in particular, oftentimes are not provided the same information, are not provided the same care. And so just like Lisa, my passion has been making sure that all communities have access not only to information, so education is important, but also have access to the resources, the treatments, because again, everyone should have the ability to survive cancer and survive it well. And so I'm grateful for the opportunity to be here tonight. And I thank you so much for inviting me to share some of my experiences around disparities that we see in survivorship care.
So for me, my passion for this important topic really comes from three important sources: my own cancer journey, the passing of a maternal aunt, and the Black women that I treat on a daily and weekly basis. I was lucky enough to have quote unquote good insurance and referral to a care team that goes above and beyond for their patients. But my maternal aunt, just like most other Black women in the US, was referred to a treating practice where it was kind of like her treatment was comparable to building a robot or building a car by a robot on an assembly line. The lack of education and transparency from a lot of medical care teams, as well as the lack of individualization of treatment in the Black community, has definitely created a cycle of disparity and the loss of too many lives of Black women. And I just think that the cycle needs to end. Too often I see and treat Black women that have had their post-surgical symptoms ignored, and their promising reconstructions kind of end up failing. They're sent to pain clinics for injections versus ultrasounds for abdominal related pain. They're not told that a mastectomy, let alone a double mastectomy, is an option, and they're really not given recurrence rates with surgical and treatment interventions. And a lot of times these women express regret over surgical choices that were oftentimes made for them and not with them. I'm really passionate about this topic because my aunt, myself, and really all Black women, we deserve access to the best information and care available to all other races of women. And I think it's important for all healthcare professionals working in the field of breast cancer to be made aware of the disparity that exists in order to bring about that change. Healthcare professionals, including myself, need to recognize the lack of education that Black women disproportionately receive regarding their treatment options. And we as healthcare providers really need to take the time to research each individual case and perform the most appropriate treatments. I mean, we can't change a woman's ethnic background, her socioeconomic class, or the biology of her tumor, but we can provide great care, honestly, no matter a woman's race.
Really so true. That was wonderful. So let's talk a little bit about your personal and professional experience with disparities and survivorship experienced by Black women. Lisa, I'd like for you to begin.
So as Janae just kind of talked about, so within my own family unit, cancer has been rampant. And we can talk about breast cancer, we can talk about prostate cancer, we can talk about ovarian cancers, even Hodgkin's lymphoma. And some of that has been related to the personal experiences of different family members, but also I would be remiss if I didn't talk about the lessons I learned from the environmental exposures that African-American and Black communities are subject to. And so that was probably one of the first things early on as a kid. I started thinking about, okay, well, why do I see all this cancer in my family? But then in the students that I go to school with of lighter hue, they might have one or two people. And so I was trying to understand that, of why that was going on. But professionally, I've been able to parlay that personal interest into research, primarily focused on the Delta area, where we've been privileged enough to be trusted and be able to work with community members to talk about what their barriers are, and also to work with them on creating community-driven solutions. So I've been really blessed and honored to be able to partner with the community in that way.
You know, Lisa, I think you and I have so much overlap in terms of our experiences. I think we talked about that early on. You know, one of the things that I think is really critical to understand in this context is that disparities exist along the entire cancer continuum. That means from prevention and risk reduction to diagnosis, and all the way through treatment. Survivorship is a component of that, but really disparities exist all along that spectrum. And so it's really vital. I mean, people don't even think about the environmental exposures, the fact that many African Americans, even Hispanic women, are living in areas where they're not homeowners. They may have other exposures. They're living in communities where there might be dumping sites nearby or other things that oftentimes get dismissed. That's one factor. But we're not even talking about the stresses of everyday life, the challenges that lack of wealth brings, so socioeconomic status and those variances, and how that can impact not only your capacity to access health, but also what that does, what that stress level does to increasing your cortisol levels and your stress hormones. We know that Blacks have higher levels of stress hormones across the board, and we know that those are things, inflammation is one of the causes of cancers. So I think this is a really, really important thing. And I can tell you as a breast doctor, I cannot tell you how many times I've had Black women from around the country call, sometimes in tears, and saying, you know, my surgeon told me that if I had a mastectomy, I wouldn't need radiation or chemotherapy. Now, I can't say for sure whether that was the discussion they had, but that's what they heard. And so in their minds, they were making decisions that were less than informed. And so part of what we want to talk about today are solutions. What are some of the things that we can do individually, collectively, and as institutions and organizations that can really improve the awareness for each step along that cancer continuum about the things that really can help to lessen the disparities gap that we see.
Oh, Janae, you're on mute.
All right.
There you go.
For me, the best way to answer this question, I think, is to tell you two true stories. As I mentioned earlier, I lost a maternal aunt to breast cancer just 2 months after she was medically cleared of all cancer. She was treated just like most people at kind of a large cancer treatment research center in her hometown. And 2 years later, through the course of her treatment, her immediate family and her extended family, which includes me, we were kind of provided with little to no education on her actual diagnosis and treatment. She underwent a mastectomy followed by chemo and radiation, the normal course of treatment. But 2 weeks after she was medically cleared of cancer, she actually began to experience headaches and nausea and vomiting. When she presented her symptoms to her care team, she was basically brushed off and told that because of what they thought was not great insurance, she couldn't have an MRI because they thought that it wouldn't be covered. Her symptoms worsened, and with persistence, her doctor finally agreed to do the MRI, but by then the cancer had metastasized to her brain. She underwent a procedure to remove tumors from her brain and relieve the increasing pressure, but when she woke up, she had experienced a multitude of symptoms impairing her cognition, her ability to speak, and her ability to walk. Realizing that her care team really didn't have her best interest at heart, we tried to enroll her in a national treatment facility. But again, with insurance, we were told until her insurance approved her being in the facility, we had to pay $250,000 upfront for her to be in this facility. Now, I don't know about you guys, but I don't really have $250,000 in my back pocket in order to be accepted in a facility. So it took about 3 weeks for us to get insurance approval. And when they called us to tell us the good news, she had actually passed away the week before. My aunt was diagnosed with breast cancer at the age of 50, and she passed away just 2 years later at the age of 52. And through the course of her journey, her medical team continued to delay and withhold important information from her and her immediate family and used insurance as a basis for decision-making. My second true story is actually my own true story. And despite knowing my strong family history, including the passing away of not only a maternal aunt, but my maternal grandmother as well from breast cancer, no strong recommendations really honestly were ever made for me to initiate early screening and mammograms. I actually found my first lump when I was 27. And at that point, you probably are thinking, okay, surely I was sent for a mammogram. And in fact, I was not. I was sent for a biopsy and an ultrasound, and it revealed that I had a benign fibroadenoma, a rather large one. And I was just instructed to return 6 months later to get a follow-up screening. Well, on that 6 month later ultrasound, not only had the tumor grown in size, but in fact, it was beginning to show signs that it was going to change to a malignant tumor. So ultimately they removed it. But again, I was never sent for any follow-up imaging until 4 years later when I experienced new symptoms. These symptoms were again downplayed as a possible fibroadenoma, but with urgency from me, I finally did get a referral over to a breast center anyway. I finally did have an ultrasound and a mammogram, and ultimately at the age of 31, I was diagnosed with breast cancer. Fortunately for me, I was referred to a group of doctors for continued treatment and reconstruction, but it was my own cancer journey that really made me see how lucky I was and the disparities that existed between my treatment and the care team and treatment of my aunt. I continued to receive great survivorship care and education, but my aunt just really did not receive any of that. And this privilege afforded to me is really not afforded to most and all Black women. And it's really about time that we not only recognize the disparity, but that a change is made.
So my professional experience really started with some of my own treatments at Turning Point with Jill Binkley, my therapist. Thank you, Jill. We designed a study to test the prospective surveillance model. Recall that the prospective surveillance model was more formally developed and dispersed by a group of experts across all breast cancer disciplines, organized by the American Cancer Society and published in the journal Cancer in 2012. The PSM involves assessing patients prior to any breast cancer treatments, then shortly after treatment, usually surgery, but could be neoadjuvant therapy, in order to identify subtle changes in baseline, so interventions can take place earlier versus later. For our study, and remember, this is the Avon Breast Center at Grady, where more than 80% of our patients are Black patients, we enrolled 120 patients and had OTs or PTs in our clinics measuring impairments that included pain, range of motion, self-reported measures of function. We compared the upper extremity functional index, the UFI, with the quick dash. Measurements were taken pre-treatment and after treatment up to a year after surgery. All patients received exercise information and education. Through our assessments, very surprisingly to me, we identified about a third of our patients in need of referral for individualized rehabilitation interventions. Statistically significant differences were found between intervention and no intervention groups in higher early post-op UFI, quick dash and pain scores, younger, not older age, higher number of lymph nodes removed, more extensive axillary surgery, neoadjuvant chemotherapy, and a higher breast cancer stage. So it's really up to us as providers to have this heightened awareness of the need for rehabilitation in patients with more extensive axillary surgery and greater burden of the disease, however, still emphasizing that in our study, some patients with lesser disease and sentinel node only required referral. So absolute number of lymph nodes removed should not be used as a cutoff. This study led to other intervention trials because once the therapists were gone and we missed those therapists, we had to figure out a simple way to measure deficits in our patients. We partnered with Georgia Tech and studied 2 devices in our clinic. The first was a reconfigured Xbox that measured arm circumference with a patient standing in front of the device and elevating her arm to 90 degrees. We found this method just as good as tape measurements, which is often a very time-consuming way to identify limb volume changes. The second device came from Lymphatech, a company that emerged from this research. They developed, yes, a mini iPad as a portable infrared 3D scanning device. A practitioner scans both arms of a patient and the device generates a visual graph comparing limb volumes. We completed a feasibility study with the help of a medical student last summer on 21 of our patients and found that 14% of patients qualified for rehabilitation intervention in the early postoperative course. The device was easy to use, only taking about 3 to 5 minutes to complete a scan, which can be done in a clinic or office setting, as opposed to having to escort them to a separate room for that Xbox device. So our next step is to use the mini iPad to train a professional in our clinic, a nurse, a survivorship navigator maybe, to take these measurements, almost like a 5th vital sign for our breast cancer surgery patients so we can more expeditiously identify patients for earlier rehabilitation referral.
These are extraordinary stories and experiences, and I think we've hit on both some motivating factors as well as where there's going to be some real opportunity for hope and change. I'd like to ask two of the panelists, are there additional barriers to survivorship support that Black breast cancer survivors face? Cheryl, I guess we'll begin with you.
So many of my patients that I treated over the years at Grady play a key role in supporting their families. So focusing on themselves, especially during that last segment of care, is sometimes easy to deprioritize. We women are busy. And after 3 months, I even moved on and just got back to work, not necessarily focusing on survivorship issues. So having said that, as champions for change, we need to get the word out that rehabilitation care is just as important as all other recommended therapies, not only improving quality of life, but also positively impacting on survivorship of breast cancer. I want to mention another program that is helping to break down barriers in our safety net hospital. We have 3 highly trained occupational therapists seeing our patients. And by the way, we partnered with Turning Point back in 2005 to help train some of our therapists at Grady. And with their expertise now, we set up a novel program where our therapists run the Self-Image Center as prosthetic fitters. And during those sessions, assess patients for need of rehabilitation referral. Making appointments convenient, often during cancer center follow-up visits, and a place close to the cancer center, the patient can just go around the corner literally, has helped reduce barriers to this service and rehabilitation care.
Thank you, Cheryl. Those were great examples and discussions into the barriers. I am going to center my conversations around an article from Palmer et al. It was published in about 2015, but I find that the themes are still pretty common. One of the things that they reported was that Black survivors, Black breast cancer survivors, were more likely to report at least one long-term side effect related to cancer or its treatment. And the numbers were, y'all, it was 80% of the Black breast cancer survivors in their study compared to their white counterparts, which were at about 58%. So the first barrier is the fact of that sometimes as healthcare providers, we're waiting on people to ask. But we know that the disease burden is already high. So how about we just be proactive and just lean into that conversation, go ahead and say, you know what, I'm going to send you to the physio or to the occupational therapist, if for no other reason than just to get that baseline data so that you can start the surveillance process. The other thing that they talked about was that Black survivors were 3 times more likely to have cost-related barriers, kind of what Cheryl was talking about. But I do want to caution the audience because Black people are not monolithic, right? So we're not all poor. We're not all, in poverty. And that often is the message that comes from the racialization of Black people. But there are some systemic issues related to poverty, which are tied to some societal policies. And so I think when you have that conversation about cost, as a healthcare provider, as a community of supporters, we also have to talk about, okay, how are we going to address these systemic issues? They also talked about anxiety and distress. And I will tell you that from my work in 3 states, that has been a common thing that has come up. Cancer-related distress, anxiety about going to the doctor, mistrust, distrust of all doctors, doctors of medicine, doctors of physio, doctors of occupational therapy, and how that there's going to have to be some extra work to build that therapeutic alliance. And the other thing that they talked about was transportation. And that has come up in every state that I have worked in, either from a practitioner or from a researcher. And some of that is tied back to redlining, where a lot of our Black cancer survivors are living in communities where you might be dependent upon public transportation, or there are health or rehab deserts in those communities. So they have an extra transportation barrier that someone else may not. And then the last barrier, which I am still, and I'm going to admit to y'all, I'm still reading this article because I'm going to have to read it 2 or 3 times because I'm still a little shocked about it, is the one from ASCO that just came out talking about how that roughly about 50%, less than 50% of minority cancer survivors are receiving care that follows the NCCN guidelines. And I'm gonna have to read that one and digest it a couple of times because that is like, it was jaw dropping to me. And when they start talking about the intersections of race and age and also insurance status and how that makes the numbers even lower, we've got a lot of work to do to allow people to have that best opportunity at health and wellness, like Dr. Karen was talking about earlier.
Thank you, Lisa. So we've highlighted these magnified survivorship issues, and I wonder if you, Janae and Karen, could talk about the impact on Black women, their family, and the community society at large.
So for me, as a cancer survivor, as well as a Black woman who's had cancer kind of run rampant through her family, I think that there's a huge impact on the family unit. I mean, the cost of cancer is honestly, it's astronomical. And depending on your socioeconomic class, many times Black women are forced to sacrifice kind of family priorities in order to afford treatment, whether good or bad. Making financial sacrifices may mean paying bills late or not at all. Possible changes in, like Dr. Van Hoos said, transportation. And depending on the advancement of their cancer, oftentimes they're forced to choose between kind of feeding themselves and their family or paying the cost of treatment or medication. Many women will kind of increase their hours at work to kind of offset the cost, but that limits the time that they have to exercise or prepare healthy meals, both of which have been proven to reduce recurrence risk. Also, these women and their lack of education and knowledge regarding proper and most appropriate treatments for long-term survivorship can lead to kind of a continued cycle of misinformation. The lack of appropriate treatment and education will trickle down through each new generation. And if Black women are unaware that they're not receiving the most appropriate treatment, they may in turn refer another woman to the same healthcare locations for treatment. And this will kind of intensify that gap of disparity that we have. And I don't know about you guys, but as a married woman and a mother, I always put my family unit before my own needs. Culturally speaking, Black women tend to choose the family unit over all other things. And unfortunately, that may also include treatment. Sometimes Black women and even their healthcare teams may choose the least amount of intervention due to cost, just to get them by. But getting by really honestly doesn't last for very long, and it in turn creates a new list of problems that may oftentimes cost more than the original problem they were presented with. Women are forced to rely on other members of their immediate or extended family for financial and physical support, possibly creating more undue burden and continued cycle of unnecessary sacrifice on their spouse, siblings, or even if there are children involved. I think that furthering the cycle of misinformation, increasing the survivorship barrier and gap is a huge problem. And, you know, we've got to address the family unit as a whole.
Yeah, Janae, I completely agree. And can I say, I love the fact that Dr. Lisa talked about Black people are not monolith. It is so true. And so we've got to be very careful not to, you know, perpetuate some of the stereotypes that are out there. But you know what? The #1 cause of medical bankruptcy in the United States is cancer care. Okay, #1 cause. So it doesn't matter. This is not related to just Black people. Okay, this is not just about Black women and men who have breast cancer. Okay, this is about the status of our healthcare system. And that's why, you know, there is societal impact. And this is why your vote matters. This is why it's important for us to make sure that we're thinking about the fact that we have an election coming up that is going to impact all of this, right? And so it's really vital. We know, and just as Janae said, first of all, I'm impressed that Janae and Lisa, your families are actually having conversations about breast cancer. Hello. Okay, so that's one of the challenges in Black communities that we know we oftentimes don't talk about family history. And so you can imagine if there is a woman or a man who's gone through a breast cancer journey and they haven't told their family. I've had that happen. And, you know, women who are going through radiation therapy after post-mastectomy radiation therapy. So they've had their mastectomy, whatever, and they're starting to have some chest wall pain, but yet they're still working and they haven't told their family. So they have like very minimal support system, right? Because again, they want to be strong and they don't want to burden anybody. They don't want to talk to their church family. Still to this day, having people that make that sacrifice that way, what happens when they become they're in so much pain that they can't function, right? And so there's all of these challenges related to not just the individual that's sitting in front of us as healthcare providers. And this is why I actually espouse having a holistic way of addressing your patients that are in front of you, right? And that includes saying, who's at home with you? Tell me about the things that are concerning to you. How would you like for your treatment to go? Just simple questions to say, I see you. I care about you. It doesn't matter who's sitting in front of you, but I can tell you that for Black women and for Black men, those questions are not oftentimes asked. And so because we're not a monolith population, neither are Hispanics, neither are Asians, neither are white people for that matter, right? There is diversity. Part of what we need to do as providers is learn how to have cultural humility. And all that simply means is asking about the person in front of you, seeing that person as an individual and saying, how can I help? And so we know, I don't know if folks are familiar with the AACR, most probably are. They recently had a report that came out around cancer disparities. This is the first one that they put out. It came out last month, and it was really around trying to draw more attention to the cancer disparities that continue to exist, even though we've described them for decades. They did a legislative briefing, so you might not have time to read the 100+ pages of that report, but at least you can go to YouTube and watch the video that dropped on 9/16, because it actually provides just an overview about some of the disparities that exist and talks about the $1 trillion deficit that we see every year because of disparities in cancer care. So this is impacting everyone, not just communities of color. If you're a taxpayer, and I know some folks aren't, but if you're a taxpayer, you're paying for some of these disparities.
So we're at the point where I think the question I've really been looking forward to can stimulate our further discussion, which is what specific actions need to take place, could take place to reduce the disparity in breast cancer survivorship that exists with Black women. Now, we could talk about this for the rest of the week, but if you could solve this problem in 15 minutes, that would be terrific. So, Karen, can we begin with you?
Absolutely. And I just kind of started into that already, right? And I think it does begin with the healthcare apparatus to start to educate providers about the importance of understanding their own implicit biases, understanding that it is important to have cultural humility, and actually educating them about the disparities. So that's why, again, I'm grateful for Turning Point for saying, hey, we've got providers out there. Let's make sure they're aware of some of the disparities that exist and some of the personal stories that there are that we can kind of speak to. The other thing is we've got to educate communities, and we have to, educate the communities that are most impacted. I can tell you, I had a 28-year-old Black woman, very similar situation to Janae, who found a lump in her breast and was passed on, eventually diagnosed with triple-negative breast cancer, and had started chemotherapy. And next thing I know, she's in my office after having a single cycle of chemotherapy. And I'm looking in the notes, and her medical oncologist has referred her to me for radiation therapy because the patient did not want chemotherapy. Sometimes we as providers have to just kind of put on our mama hats or something else and say, you know what? Let me share with you what the statistics are, right? And I did that with that young woman. I shared with her the statistics. I said, Black women are dying of breast cancer and they don't need to. And our job here is to really provide you with all of the options on the table. We really want to make sure that you can get through this. We're here for you. And it doesn't take that much. People just want to know that they're heard, that they're seen, that there's side effects, because she was having side effects from the chemotherapy that were not being heard and were not being managed. And so we have to do that as providers. And I think that's an important thing. The healthcare system we know is broken, but what can we as parts of the healthcare system do to see that person who's sitting in front of us individually. What can we do for that individual? And how can we make sure that everyone has the opportunity to understand what options are available to them? It's things like this, scenarios like this, webinars like this, but it's also educating the communities before they have a cancer diagnosis and educating the individuals who are sitting in front of us around what their options are.
Karen, I couldn't agree with you more. Honestly, I think one of the most important things that we can do is to provide education to healthcare professionals and patients. I think that the more awareness and education there are among healthcare professionals regarding the disparity that does exist, really honestly can be that first step in bringing about change. On the other hand, patients need more education on early screening, risk reduction, pre and post diagnosis treatment. I think they need education on all of their surgical options, including the risks and benefits of each and why certain options may provide a more optimal outcome for their specific case. I think that a lot of times patients aren't given all the education on why they need a lumpectomy versus a mastectomy, a single versus a double, reconstruction or no reconstruction. And if they do get reconstruction, a lot of times they're not given an option on the type of reconstruction that they receive. I think we need to educate them on medications, and the side effects that may occur with some of these medications, as well as, like you said before, Dr. Wingfield, recurrence risks and risk reduction. I think we need to provide education, not just one time, maybe not twice, but maybe a third time, because as a survivor, I really understand that there are so many things running through your head that you have to deal with. So you may not hear it the first time or the second time, but maybe by the third time, you're really beginning to try to process that information. Patients oftentimes are given a folder or a pamphlet and they're just kind of sent on their way and expected to read and understand. And they just really, it kind of gets put on a counter and then they don't ever see it again. I think the second most important thing that we can do to help reduce the disparity is to treat the individual patient. There are no two cancer patient cases that are ever alike, and treating a patient as an individual can drastically, I think, reduce these disparities that do exist. Treating breast cancer means treating the person as a whole. And we as healthcare professionals, we really need to understand that no two symptoms are not related. So if a breast cancer patient comes to us with complaints of back pain, we need to ensure that that back pain is not related to breast cancer and get them some imaging first before we do anything else. We need to ensure that if they complain of a headache, those headaches aren't related to breast cancer. We need to ensure that if a Black breast cancer patient with lymphedema complains of a fever, she's not developing cellulitis or some sort of systemic infection. I think we as healthcare providers, we really need to look beyond race as a basis for treatment and really open our eyes to the individual in order to provide education and the best treatment outcomes possible.
So similar to Karen and Janae, my plea is a need to come together as organizations, associations, communities, hospitals, physicians, and physical therapy practices to get the word out about the importance of this last segment of care. I can't emphasize that enough. We own it. I'm reminded of a study that was published by the Avon Foundation in 2016, examining disparities of breast cancer care in the 50 most populated cities in the United States. Atlanta has an interesting story because we were successful in closing the disparities gap of breast cancer care and treatment between Black and white women in the early to mid 2000s. Their survival rates equalized, although as a city, little embarrassingly, we were less than a national average. However, from 2010 to 2014, the disparities gap measured by death rates all of a sudden widened again. And it's interesting that this correlated with the crash of the economy in 2008. And as women and patients lost jobs, they had a perception that resources weren't available to them for breast cancer care. We as providers need to speak up and let the communities and patients know that programs still existed to fund breast cancer care. And the analogy is similar to breast cancer rehabilitation. We've been talking about stressing the importance of survivorship care over a decade. So it is now up to us as providers to talk to patients, encourage patients, and refer patients for breast cancer rehabilitation. If we don't speak up, our patients will not benefit from this life-saving care. Finally, we have to come together and figure out ways to improve access to care. treat the patient individually. For some women, it may be an in-person visit. For other breast cancer survivors, it may be telehealth. And I'm really honored to be part of a group of researchers organized by Turning Point through 6 different countries who are looking at the telehealth platform to reach underserved women in different walks of life. And like I said, in different countries. And so that's a very important tool that we cannot forget, because for some women, that may be a more convenient modality to receive their care. Either way, we have the tools. They've been well tested to reach out to our patients for this vital component of care.
Thank you so much for talking about the Turning Point Research Project. I'm going to frame my response in a logic model. It'll help me also be concise. Under the short-term goals, y'all, I think the first thing is just listen and seek to understand, be curious, and recognize the doctor in front of you. And your knee-jerk might be, well, Lisa, the patient I'm seeing or the client isn't a doctor. The term doctor, the origin of the word, means a learned person. So that person sitting in front of you is a doctor of their own lived experience. And so you need to recognize the doctor in that person. And then whomever your discipline is, be it your physician, PT, OT, then at that point, you're partnering to work with that person in regards to their needs related to your skill set. So I just say recognize that human and their expertise, because sometimes as healthcare providers, we come into this with a hierarchy that's unnecessary. The second thing is to screen for social determinants of health. To me, that's a short-term thing. It's a short-term goal. Everyone could start doing that tomorrow. And there's a ton of recommendations out there. And also, as you're screening for those social determinants of health, I am very biased. I think we all need to be screening for distress. Our team has researched the distress thermometer, so I am biased towards it, but I find that problem list to be fabulous. And the fact that you can customize it for both geographical and cultural needs, I love it. And Dr. Karen talked a lot about how that the things that we see in the Black community are lessons or even experiences that we're going to see in other communities. And one of the things that you probably have heard me say in a public space before is that if you want to know where the white community is going to be 20 years from now, look at what's going on in the Black community, right? Because poverty will only stay within those boundaries for so long. So the practices that we put in our society to keep certain groups kind of insulated and contained, we can only control that beast for so long. And I think COVID is teaching us that lesson right now, because we're starting to see the impact of poverty and low education in other communities, not just Black and brown communities. And so I think we as a society, as Dr. Cheryl was saying, we've got to realize how connected we are and come together. Because my community's problems, if they're not your problems right now, or if you're not recognizing that they're your problems, sooner or later they will knock on your door and ask for a moral reckoning. So that's my short term. I'm gonna go faster, Bob, I promise. Then my middle is navigation. I think every patient needs a navigator. Our healthcare ecosystem is so complex and so fragmented, and we've seen really good success with that in brown communities. I feel like Black communities especially need a nationwide, state, grassroots, however you want to do it, but we need navigation programs. And then somehow we need to work with our city leaders to incentivize or promote the re-entry of grocery stores, physical spaces, green spaces back into those communities, all of those things that we can use for primary and secondary prevention. And then my last thing that needs to happen, my long-term goal, is diversification of the workforce. Because that conversation that Dr. Karen had, it helped that she had the complexion to have that conversation. And it is what it is, people. People are more likely to sometimes have those uncomfortable conversations with someone that may look like them. or at least has a cultural affinity very similar to them. So workforce diversification is one of these things we have to keep talking about. And then lastly, as healthcare people, we have got to advocate for communities. Healthcare workers, we make really good money. We are in the upper quartile of society. But if we're going to talk about health and wellness, then we have to advocate for social justice for all.
I've been listening to these answers, and I can tell you, everyone who's on this call would hope that if they got sick, or if a family member got sick, that they would be treated by you for. And not everybody's going to have that opportunity. But we all know we do this, even in networks. Cheryl and I are here in Atlanta, and when someone calls me, I call Cheryl. How do you, we've been at this for a long time, and when we say education, I keep thinking there's no shortage of education. I mean, there certainly are plenty of things that women are not told, and will tell you, I never heard that, I didn't know that, no one's ever mentioned that. But are there, can you think of what we might call structural things that might raise awareness in institutions, where institutions would hold all of their employees responsible for rising, to a higher standard of care that could be measured? We talk about implicit bias. You ask any healthcare provider and they would tell you, we treat everybody the same way, everyone the same way, with the same kindness. They get the same information. I don't spend any less time with any other patients than any others. How do we open people's eyes, and how do we open health systems' eyes to persistent disparities?
So can I say that's part of the problem? You can't treat people equally. You need to treat them equitably. And there's a big difference. And I think that's part of what we've got to get into people's head, is that not every one person is the same. Dr. Janae talked about that today. You need to look at the person who's in front of you. And that's one of the things that we don't do well in healthcare, because we're rushed. And I do disagree a little bit. I know that people think that they've been out there and that there's been education, but I can tell you some of the educational materials I've seen, there's not a brown face on it. There are entire institutions where you look at their website and you go from one page to the next, and there's not a single black or brown face that is represented in there. And so who are you educating? Again, to that point, there's a disparity in terms of not only how education is provided, but to whom it's provided. And so that's an important factor. We've got to make sure that in communities of color, we already talked about the fact that sometimes in Black communities, we're not always talking about cancer, but that's not just Black communities, that's Hispanic, that's American Indian, that's oftentimes Asian families, that the C word is still kind of seen as something that you don't talk about. And so it's really important to make sure that the educational materials that are done and who is doing the education, that's where the concordance comes in. Like I said, Lisa, we are right there, Dr. Lisa and I, the workforce diversity, and it's not just the physician workforce. It's not just the healthcare professional workforce. We're talking about healthcare workers, navigators, et cetera. I believe in lay navigation and have had and developed community health worker programs because it's about who is doing the education and with what materials, and making sure that there's cultural sensitivity and cultural appropriateness for that.
Mm.
I'd like to also further emphasize the role of navigators. We were very lucky to be funded by the Avon Foundation for many years. And it was Otis Brawley who developed that lay navigation program at Grady. And they were women of the community, like the community. Again, the Harold Freeman model from way back in the 1990s. And we took that model and implemented it at Grady. So they were actually cancer survivors who would staff our clinic. So when I actually went in and told a patient about her breast cancer diagnosis and talked about the initial steps for the treatment, there was a navigator right there listening, and a navigator who could come in and say, look, I'm a survivor. You can survive this. This is the plan. This is what you have to do. We had clinic navigators. We had navigators who would call you up on the phone if you needed to talk to somebody on an urgent basis. We had navigators who would come to appointments with you. It was fascinating. As we received some funding from the Merck Foundation, we hired nurse navigators. And we asked ourselves, do we really need these lay navigators still? However, we found that the nurse navigator provided the professional, I can expedite the care, I can move up this appointment, I can get this provider to talk to that provider to, again, make your care more efficient and timely. But we kept the lay navigators, and we kept the lay navigators because they are a living testimony of beating breast cancer. They communicate with our providers. A lay navigator could come up to me and say, Dr. Gabram, the patient didn't understand what you just said. You need to go back in there. You need to call the patient. And so I really want to emphasize the role of navigators and layering navigators. It's not one or the other. Lay navigator, professional nurse, or social work navigator. I think they all are important in our networks.
So Cheryl, to your point, I do believe in lay navigation as well, and I've used it quite extensively, even in my role at my last role where I was the Associate Director of Cancer Center, and we had it combined with nurse navigation. I think it's also much easier actually to get lay navigation that's culturally concordant, right, and linguistically appropriate, versus nurses where there's certainly a shortage across the board, again, with workforce diversity at the professional level. And so I don't even require that my navigators need to be survivors, because sometimes the survivors can actually layer on their own experiences and it can get a little cloudy. So there has to be a lot of training around that to help them to learn how to disassociate. But the fact of the matter is just having someone who speaks the same language, and I'm not talking about Spanish or Arabic, that's fine too, but just the same way that I could go into a patient and be like, hey girl, right? It's a whole different ball game when somebody knows that I am familiar with where they're coming from, and to have those conversations. And so that's one of the things that I've been very much a proponent of, is making sure that navigation exists. And to your point, the nurse navigators, they have a role, but so do the lay navigators. So thank you for reiterating that.
So the only other thing I'm going to add to this conversation about structures is talking about just slavery. And the reason that I'm bringing it up, and for some people are like, why does she keep doing these historical references? Because the history are the bricks that build a house, right? And so although, yes, we are moving forward, we still have to figure out what we need to dismantle to be able to do it well. And so with slavery, when you're having a conversation with someone about their history, which is so important for cancer care, you may not know your third or fourth order, ancestor, or you may think it is someone that it is not, right? Because that is one of the byproducts of slavery. And you don't just see it in Black communities, you also see it in Irish communities and also in European American communities where those people were of lower income. So a lot of times who we're thinking as our grandma, our aunt, or our uncle may or may not be. And so it leaves a door open for us to have a conversation about genotyping and admixture as a way in which to get a better understanding of who you are as a person. And I know that Black communities, there's some hesitation to that, and it is very well deserved because we have done some really mean stuff to certain communities within the US. But I do see genotyping as a way in which to give some people some information to make some more informed choices about their cancer care.
Yeah, that's insightful. So can I just ask, you've each mentioned the value of navigation. There's been an IOM report on navigation. We've all seen that it's magical, really. Why are we still having to fund it with grants? In other words, we've seen examples where you could even show a return on investment that was startling, and it's still a hard time getting the system to pay for navigators. I have a colleague on the West Coast. You mentioned how important it can be for some people to have somebody of their same race and ethnicity be their caregiver because they can just relate to them. And then sometimes that's just impractical, but she keeps a list of patients that she's treated for lung cancer and says, can I call you to talk to someone like you, because sometimes they don't want to undergo treatment. You've been successfully treated, and I think it would mean a lot if they could speak to you. And she says it's working very nicely, and we're going to try to do a study on it so we can say this is an alternative if you can't match patients with providers. But I'm still puzzled about the navigation, why we can't fund navigation. Do you have any thoughts about this?
Because we need to get out and vote. So
yeah, apart from that, right?
I'm just saying. But again, our healthcare system is broken. And I think when you look at institutions, there is still a cost associated even with lay navigation, right? It's one thing to use volunteerism. And so that's one of the things when I go and I talk to my community partners, we know that most of cancer care 80% of it happens in the community setting, not in the big academic centers where we can write the grants, right? And we can get those services. Most of it happens in the community. And that's where kind of having community partners and having patients or advocates who you can call on is really instrumental. And I say to my colleagues who are in the community setting, do not hesitate to reach out to your patients and look for those volunteers who might be willing. But I still think there needs to be some training around that advocacy piece and really making sure that people have the tool sets they need, because it can be really hard when you're hearing stories. That's why in the Black community, sometimes there's some hesitancy even to joining support groups. Like if you say call it a support group, folks don't want to do that because they have a connotation of people sitting around complaining all day. But I do think that unfortunately, there was a study that came out early on, and I think this was about 12 years ago, that suggested that navigation was too costly. It was not cost effective. And that has stuck in the minds of a lot of folks. And so part of the challenge now is showing what the return investment is. And I think there are more and more studies that are coming out around that. But then I think we really need to make sure that insurance companies understand the value of it, understand that we can make sure that people stay on task in terms of their course of therapy, and that by people getting treatment in a timely and an orderly way, we actually can prevent women and men from having, to have recurrences. There are so many reasons that we can give, but it's that business case again. And it's a shame that we have to use the business model all the time, but we do. I mean, it's a business. Medicine is a business in this country. And so you have to use that business case. And I think the onus is on, again, us as healthcare providers, those of us who have utilized that tool set of navigation, whether it be lay or nurse navigation, to really not only produce the data, those of us who can, but then also to advocate at our home institutions for that, whether it be even navigation around survivorship care, right? Those are all of the things that we need to do. Financial navigation is a whole other beast, so I don't want to talk about that. But I don't know, Cheryl, you might have some other ideas.
I wish I did. I wish I had a bigger piggy bank too, because even as we transition from our Merck grant wrapping up, we're doing an ROI for nurse navigators, just to prove to the institution that these folks can save money and can, save money for our patients and help our patients, get the right treatments. So it's all about the data. I think it's collecting the data and showing it to your institution, sharing it with the community, sharing it with some of the community hospitals if they don't know the templates of how to do an ROI and figure that out, as well as I really like your comment about the insurance companies, because we did that for genetic testing in the state of Georgia through a CDC grant, and we were actually able to get our insurance companies, Medicaid, to cover some of the testing when they didn't before. So
yeah, there was a comment in the Q&A box about Medicaid and Medicare potentially paying for visits and for check-ins, but that usually is for people who are credentialed. Right. So that's where, sometimes having a nurse navigator is somewhat beneficial because they might be able to charge for something, not so much for lay navigation, but that also is being looked at and changed. I know Tennessee and North Carolina both have are working towards the development of credentialing for lay navigators as well, as a way to make sure that there's a greater workforce that could really speak to this. But then it is a matter of us also making sure that we are advocating on behalf of our patients and saying navigation works. We see benefit in both lay and professional navigation, and trying to make sure that we can at least collect some dollars, because I must say it's not always fair. And this is what happens in the Black community. The Black community is that Black tax, right? Where we get asked, we're like, well, do it for free for your community, right? But I do think that if we're asking people to utilize their expertise in terms of doing community outreach and engagement, we need to provide some support for those individuals because they're taking their time to do that.
Just to add on to what both Dr. Gabram and Dr. Wingfield were saying, a lot of times because that navigation is so quote unquote not cost effective, as a physical therapist working at Turning Point, a lot of times I turn into that nurse navigator. I've seen patients that have had surgery and treatment and have never seen an oncologist. And I'm just kind of dumbfounded. How have you not seen an oncologist, but you've had surgery and you've had treatment? So a lot of times at Turning Point, we tell patients, if you don't get anything else out of Turning Point but to be your own advocate, then I'm ecstatic. We really try to teach patients that you have to get that second opinion if you feel like something's just not right. you know your body better than anybody else, better than me, better than your doctor. You know when something's not right. So not only are we advocating for them to be an advocate for themselves, but we're also sending them where we think is appropriate, and appropriate referrals to an oncologist, to another plastic surgeon, advocating for them to get a second opinion on chemo, a second opinion on radiation. And it's just really unfortunate that we haven't been able to prove the cost effectiveness of it, but through working at Turning Point, I've seen that it works, and I know that it works. And so we really got to figure out a way to kind of, like you said, get insurance companies on board and really show them that what is happening can continue to happen in a great way if we get everyone on board.
Janae, one of the barriers that I've seen actually for patients getting a second opinion is the time it takes for them to take off from work even, right? So I think that's one of the things that we need to work on as well is from the employer standpoint is giving women and men time to actually explore options, because that's a big challenge, right? So, and even with getting some of if they need physical therapy, there's a challenge with that sometimes. And I think a bigger challenge in the United States is the way that our insurance is actually tied to our employers. I get insurance through my employer, and they request that you see somebody within network, right? Or else you have a higher copay or co-insurance. And so sometimes people can't get a second opinion because if they go out of network, they're being charged exorbitant amounts of money. So I think these are some of the things that we need to think about globally. And believe me, I'm a policy person. That's why I want folks to look at the AACR policy report, that progress report, because it was built and designed to really to talk to legislators about some of these issues. Again, I believe in the process. And so it's just a matter of us educating each other and educating our patients about things. But it's really hard in the current system and environment where, people might want to get a second opinion, but it can be a challenge.
So
This has really been an excellent discussion. We have some questions from the attendees. Jill, do you want to come on?
Yeah, thank you, everyone. This has been an amazing discussion. I do have a few questions. There are a lot of them, and I know that I won't do them justice, but let's start with one. And I think because it goes right back to the beginning where we started, which is that you all shared your personal examples of when breast cancer patients are often told that really they weren't listened to and did not receive effective care. But it seems like equipping women with the knowledge and skills to self-advocate is going to be a problem when they're existing in a racial and discriminatory system. Basically, how do we equip women with the system that's a problem? It sort of goes back to educating women to be self-advocates, but they're working and dealing with a systematic racism issue to begin with.
So Jill, I love synchronicity because that was actually, I saw that question in the chat and I was going to jump in before you came on board. So one of the things that we had worked on originally with a PCORI project was going into the community and finding out what would self-efficacy look like for that community. And we allowed the community to define their cultures, however they wanted to define. And it was interesting that people just naturally kind of dissolved into these racial and ethnic groups. But I think it was because of the commonality in language. But what we kept hearing from community members was they wanted to be able to present data back to their hospital system, to their healthcare system. And I remember one of the participants speaking up about the fact of that I constantly read reports about how they perceive us, but where's the report that comes from us about how we perceive them? And so that empowered this group, and they actually are still, I think, in the Northwest Arkansas area, putting together, like they put together their own little report about, and I shouldn't call it little, they put together their own report about their perceptions about the care that they receive. And I think there are ways in which we could work with community members to empower them to understand, like, both qualitative and quantitative statistics. And here's how you can present this data. And this is what gets our attention. So there might be a way in which to empower the community to have a similar language that the healthcare system values. The other thing that I just wanted to throw in there also is for us not to forget about the caregiver in that entire unit, because cancer is it's a disease of a unit. And that may be another way for us to have this conversation about navigation, is because right now the economic assessments are all being based on one patient's care and that cost savings there. But we almost need to be talking about it as intergenerational, right? How an insurance company is going to save cost over an entire unit, because we know of the long-term impacts of cancer on that entire unit. And that's a bigger number, and that's a bigger conversation about, yeah, you as an insurance company, you're doing this thing right now that you think is going to get you savings 2 or 3 years, but because of the lack of navigation, here's going to be that increased cost, not just for this one human, but for the 3 or 4 or 5 other humans that they touch. So I think there are some other math, some other statistics that we could bring into this conversation with insurance companies.
And I'll just add, Jill, I think when it comes to empowering women who are from disenfranchised backgrounds, it does take time. And it's hard because we can't be everywhere. Those of us who are passionate about this work, I mean, I did a study in Boston looking at perceptions of cancer care and clinical trials amongst Black population. And that was several years ago. And I can tell you that nothing has changed in terms of, to your point, all of the systemic issues that there are that are barriers in prevention. You know, Blacks are still only comprised less than 3% of cancer clinical trials. And so, you know, we know that those barriers still exist. But looking at innovative strategies, I know my colleagues and I, 2 medical oncologists and I, started a podcast called 3 Black Docs. And we want to be able to have conversations that are directed at communities of color and just break it down and say, here are some things, here's a toolkit, here are some questions to ask. Do not leave your doctor's office without having this answered. You know, here's the question if you go in for your mammogram, and here's some things that are happening. So just breaking things down in ways that people can hear. Because I tell you, in my work and the qualitative work that I was doing in Boston, you know, oftentimes people feel, again, that while there's education materials out there, nothing's for them. It's not for them. And so meeting them where they are, whether it be a radio show, we've done radio shows before, I've done TV shows. I mean, there are things that we can do to really help to empower individuals to know that they have the right, that they are the ones who can control what is happening in the doctor's office, but it does take reinforcement, but we have to do the education where people are.
I think just adding to that too, really quickly, I think what Dr. Wingfield and Dr. Van Hoos were saying, strength in numbers. So the more family members or friends you can educate of that person going through it, the better. Bring people with you to the doctor's office. You may not get all the information when it's told to you, but maybe your family member heard something that you didn't hear. So strength in numbers, getting the more people you can involved in your life, involved in your treatment, is also going to be another way to kind of self-advocate. And if they're in your life and they're a friend, they're a family member, that means they're there for you and they want nothing but the best for you as well. So getting as many people as you can involved with your care and your survivorship is really going to make a big difference.
I have another question. How has the expansion of telehealth improved both communication and treatment options for underserved and unserved patients?
Well, one of the challenges in the United States is that there's a digital divide. And so while, I received several grants from the National Cancer Institute to work on rural health, right? So I mean, in North Carolina, 80 of our 100 counties are rural. So I understand that telehealth has been seen as this wonderful new tool, even though it's been around for a long time, but now we can actually get reimbursed for it, which is great. Should have happened a long time ago, but thank you, COVID. That's the one good thing from COVID that's happened. But I do tell you, there are some challenges with telehealth. And has it allowed for expansion? Yes, but there are some communities, remember, even in some of my rural communities, where they just don't have broadband access. They may not even be able to have good telephone access. And we know that in Black and Brown communities, even in urban settings, there oftentimes is a digital divide. We're seeing that now with the schools, right? With the schools now being virtual and families needing to get computers and other access to internet, et cetera. So while I think that it certainly may be able to expand access to follow-up care, that there is still that digital divide that we need to be very conscientious of, and making sure that broadband exists broadly throughout our communities. But then there's nothing like, kind of when you have lymphedema, being able to go in and having a physical therapist lay hands on you, right? Or when you're having chest wall pain. I saw that somebody's talking about chest wall pain. I refer my patients all the time to go and actually see a physical therapist, because that's important. Yes, there's pain management, et cetera, but sometimes you can just have tightening of that chest wall. So there's nothing like having somebody put their hands on you. But yes, I do think that there's some benefit to doing telehealth, but it's just not the panacea that everybody would like for it to be. That's just my opinion.
I just want to follow up on something that Karen said about follow-up visits, because I think what we learned in the Cancer Center at Grady was that when everything went into that lockdown, the first kind of 6 weeks in March, April, May, that telehealth visits were effective as follow-ups. New patients, that was absolutely difficult to do. But I think that, we had these guidelines from ASCO that said you have to see your surgical oncologist, and then you see your medical oncologist every 3 months, and then radiation, and then survivorship, and you want to rotate every 3 months. I think one of the epiphanies we had is that the telehealth platform, even if it was just a phone call, didn't necessarily need the video conferencing, it kind of worked, and it made people feel a little relieved that they could be talking to someone. So I am not at all suggesting a replacement, but I think we will continue past pandemic to think about the role of telehealth to help people, because a lot of our women needed the transportation or someone to take care of kids to come and see us. And how can we make it easier, especially for that follow-up care? And maybe Janae can comment on about treating patients from the telehealth platform at Turning Point, because you have experience with that.
Yeah, let's move to the survivorship side. Janae, do you mind talking a little bit about telerehabilitation as far as increasing access to patients?
Well, I think that what Dr. Gabriel was saying is absolutely true. We've been able to reach an extensive amount of women through our telehealth platform, because it doesn't just include our PT sessions, but we've also been able to reach more women and men through our workout programs that we have online, our educational events. We've actually been able to increase, instead of one educational event a month in the clinic with a limited number of slots because of our clinic size, we're able to open it up to kind of really unlimited space, and we're able to do one, sometimes two a month instead of just the one that we were offering before. I've been able to treat patients that have actually been kind of, believe it or not, stuck in other parts of the country. They went on a vacation and got stuck there because of COVID and couldn't come home, but still needed at least some sort of treatment with PT. So I've been able to reach people on a larger span. I think we've been able to educate more people as best as we can through the telehealth platform. And I think we've brought about a lot more awareness through this telehealth program as well. I do agree with you, Dr. Wingfield. There are a lot of disparities that exist in terms of maybe access to the best internet options or even computer options. I've had patients that say, I can't get on the computer, but I can call you. Can we do something like that? And it's been a challenge, but we've been able to make it work. So I think that sometimes, just like what Dr. Gabriel was saying, sometimes just having someone you feel like, we're in the middle of a pandemic, but I can still talk to you on the phone, and I can still get some information and still get some sort of guidance that helps me get over a hump until I can see you in person, has been really remarkable. And the amount of people that I feel like I've been able to help through the telehealth program has been much more than I ever thought it would be. We were kind of thrown into it with COVID at the beginning, and we kind of, stumbled a little bit in the beginning, but I think now we've got a hang of what we're doing with it. And I think we've been able to kind of perfect that. And now we're transitioning people into more of a in the clinic and telehealth program, where some of their visits are in the clinic and some are still on telehealth. We've been able to see people more because now maybe they don't have to take time off from work to come into the clinic for an appointment. I can see you at 7 o'clock, 7:30 in the morning before you go into work, or I can see you at work at 7 o'clock in the morning before you clock in for work. And so it's been able, I think people have really been open to kind of finagling their schedules and figuring things out and still feeling like they're getting good care through the telehealth. And then now creating a hybrid program where we see people in the clinic and through telehealth. So it wasn't what we expected, but I think it's better than what we expected, to be honest with you.
Thanks, everyone. Unfortunately, it's 5:27. We do want to wrap up and talk about next steps because this is just the beginning. If it's okay with you, Bob, I'll take over and just finish up. Everyone is going to stay on, but I'm just going to share a couple of PowerPoints just to give people some direction. First of all, we did not get to all the questions, and I apologize. And there were several questions related to community involvement and how we can help. And so my first slide addresses this. This is just the beginning. Turning Point is now involved in doing an ongoing issues in breast cancer survivorship series. And we did not believe this is the end, and we knew this coming into this. We are going to continue with our topic of racial disparities in breast cancer survivorship for several more webinars. And we are going to continue the conversation where we can bring in advocacy groups, patient perspectives, continue to have conversations like this with experts. But I think today we've really laid out the problem, just really begun talking about what we can do and strategies for change, but the conversation isn't over and we're not going to leave it here. So we have your emails, we will be in touch. I did want to thank
Jill, you're on mute.
few technical things. Our champions for change. These are experts in the field, some of our panelists today. They're researchers, clinicians, and they have been listening to our webinar, and they have given us their support to walk along beside us as we continue the conversation on disparities in breast cancer survivorship. We are thrilled to have them, but we also want to grow this group. And I'm going to give you some contact information in just a minute. And again, the conversation will continue. So thank you so much to these people for their support. I want to thank our panelists and our moderator. You guys have been amazing. Thank you so much for spending time with us out of your very busy schedules. It's been wonderful. Thank you. I also want to thank our sponsors. They made this possible, and sponsorship dollars will go directly to continuing our conversation, as well as our direct outreach to women of color in our Atlanta community, as well as some of our projects, as we've talked about, increasing access to care for women across the United States and indeed around the world. I want to give a shout out to two of our very special sponsorships. They are patient directed sponsorships. And that I think is really important, that our past patients have stepped forward. One patient actually put out a challenge to our other former patients to meet her challenge of a sponsorship. And then one is in memory of one of our very special patients and friends, Alice Stubblefield Memorial Sponsorship. Thank you so much for all of our sponsors. Thank you also to our partners. These groups have been very critical in spreading the word about today's forum, and we deeply appreciate their support. And finally, as I said, we will be in touch with future events. There's our Turning Point website is there, our contact information. BC Survivorship at myturningpoint.org is a email that you can reach us if you have questions, comments, or want to get involved. Thank you so much once again to our panel. It's been a wonderful session, and we'll see you on the next one. Thanks, everyone.